Hi everyone, welcome again to the Borderline Personality Disorder Family and Consumer Education webinar series. Today we're joined by Dr. Mark Schechter, who's going to be speaking with us on suicide. Dr. Schechter is the chair of the Department of Psychiatry at North Shore Medical Center, and he's an instructor in psychiatry at Harvard Medical School. He has devoted a lot of his career to clinical work with patients experiencing suicidality. He's also done a tremendous amount of work both in writing and with professional societies about the study of better suicide assessment and suicide prevention strategies, and he'll be sharing a lot of that information with us today. Before we get started, a few logistical announcements. We want this webinar to be as interactive as possible, but all of your identities are hidden from each other. Nobody can see your email address or a phone number. In the lower right-hand corner of your screen, you'll see a Q&A box, and we encourage you to type in questions or situations that you're struggling with in that box, and we'll get through as many of them as we can. If you've come to this webinar with a specific question in mind, feel free to type it in right now, and we'll put them in queue. In the lower left-hand corner of your screen, there are links to multiple websites. The second one is a link to all of the webinars that have taken place, and so you can view recorded webinars, and you can see upcoming webinars and register for them at that site. That first link is a new one, and it's International Survivors of Suicide Loss Day this month, November 18th. We have more information about that at that link, and so we encourage you to go there. And finally, I just want to again remind people that these webinars are brought about by a generous philanthropic gift from a family affected by borderline personality disorder. We would love to be able to continue them further on, and in order to do that, we would need additional support. So if you're in a position to be able to support these webinars with a gift, small or large, we encourage you to do so. And there's a link on the web resource, in that web resource box to support these webinars. And with that, I will turn the webinar over to Dr. Mark Schechter.
Well, thank you, Chris. Thank you for having me here. So I'm going to talk about suicide, and I thought the way I would structure it is I'm going to provide some information, but some of the way I'm going to do this is to talk about certain myths about suicide that are kind of pervasive in our culture and society, and I'm going to pepper the talk, as you'll see, with a number of statements, and then we'll just talk a little bit about whether they're true or false and why that's so based on what we know. How do I change slides? Oh, there we go. So just as a quick overview about the problem of suicide, I'm sure we're all here because suicide is a huge problem, and it's a huge national problem, and it's actually getting worse. Suicide occurs about 41,000 times in the U.S. in a year, based on 2014 data. And it's the only leading cause of death that's actually trending up in the past decade, which is really concerning. It's the second leading cause of death for younger people, ages 15 to 35, and it's actually the 10th for all ages. And actually more people die by suicide than homicide or motor vehicle accidents, which astounded me when I learned that, and really puts it in context. It's a major public health problem. Also, even though in psychiatry we're the ones who really think the most about this, treat patients most intensively and study it the most suicides occur when they're not in our practices. More people have seen a primary care physician or an advanced nurse practitioner in a primary care office proximal to making a suicide attempt than have seen a psychiatrist or psychiatric clinician. And I believe some of that is not coincidental. I think sometimes people go to the doctor as kind of a last gasp, hoping maybe someone will ask the right question or open something up, and then leave, and then that sometimes is kind of a last straw phenomenon for them. But people are often help-seeking just before completing suicide. So before getting into too much, I like to start by talking about what is it like to become suicidal. It's not something that you can capture with a diagnosis, and it actually cuts across all diagnoses, and it's really not something you can quite capture by talking about the kinds of symptoms that are listed in a DSM-5. In general, the literature tells us, and if you talk to enough patients who struggle with suicidality, what you learn is that it has to do with, more often than not, a wish to just escape how somebody's feeling. That it's an unbearable feeling of anguish, despair. People have used all sorts of terms. There's been a term coined psych-ache, mental pain. Marsha Linehan, who developed DBT, calls it emotional dysregulation. Really, everyone who has studied suicide virtually talks about this unbelievably horrible way of feeling that feels intolerable, and it also starts to feel timeless. When people start to feel this way, it's like they've dropped into a pit and they can't even imagine being outside of the pit. There's no before and there's no after. And so when people start to feel like there's no way out and suicide is the only option, that's when we really get concerned about the risk. And the sad thing is, or the hopeful thing is, that there is a way out, almost always, and that it's not timeless, and that it's not as hopeless as people generally experience it. So if we can help them with that, we have an opportunity. And one of the points here is that sometimes even a very small thing can tip the balance. Someone's feeling that desperate and alone, and sometimes a small act of kindness, one person who sits down with them and kind of gets through, one nurse in the emergency room who seemed nice and the person was able to talk to them. So people will say, that was the difference. That's when I decided to tell people how I felt instead of acting on my thoughts. So here's my first kind of true-false statement. Suicide can be predicted if you just do a thorough evaluation, and that's just not true. What we can do as clinicians is what we call a suicide risk assessment. So what is that? Well, it's not a checklist. There are lots of checklists that float around, but there are no checklists and no scores, no adding up of factors that give us a suicide score and tell us really anything meaningful. What it is it's a cognitive assessment in which the clinician, the psychiatrist or other clinician, tries to weigh a variety of factors, some risk factors that are static, how's the person doing right now, other factors, what's their behavior been like, and to come up with a thoughtful assessment about the patient's immediate risk and needs versus longer-term needs and goals. So it's not a prediction, because some people who are evaluated as low risk, legitimately low risk, actually kill themselves, and some people who are very, very high risk actually never go on to kill themselves. So it's really not a prediction. So let me say a little more about what we mean by suicide risk assessment. What do we take into account? Well, there are risk factors, and by that I mean the static things that you can know about someone based on their history and demographics, and we'll go through a few of those. There are also what I call mitigating, but what in the literature is called protective factors. Those are things that might help to counterbalance somebody's feeling suicidal, such as, I have a family at home, I couldn't let them live without me. I care about how my spouse would feel. I know it would be devastating for them. Good relationships, a sense of belonging to other things beyond yourself, like belonging to a religious organization or being part of a community. These things make a difference. They're not completely protective, which is why I call them mitigating, but they make a difference, and they're part of what we weigh in a risk assessment. Has the person communicated about their suicidal ideation at all? Have they hinted at it? Have they hinted that life's not worth living? Have they told a clinician? Have they hinted at it to family members? Have they made any kind of preparations at all? Have they written a note? Have they started to give away any possessions? Have they been practicing in some way? Do they have a noose at home? Have they gone to a bridge that they wanted to check out? All of these things become very worrisome in the risk assessment. Do they have the means available? Like if they have an idea that they would shoot themselves, do they actually have a gun? If they do, that really increases the risk. And finally, just what's the person's mental status? What's their current clinical condition? How likely are they to act? So these are the things that cognitively a psychiatrist or clinician takes into account as we assess suicide risk. So let's talk about risk factors, which, as I said, are the static things that you can know about somebody. Sometimes without even talking with them, you can know even from looking at, a lot of them from looking at the record and the history. So one is just having a psychiatric illness at all. Really, all major psychiatric illness confers an increase in suicide risk above the general population. What we do focus on most is depressive disorders. The risk is really high there, and particularly really any kind of depression, unipolar depression, bipolar depression, so bipolar disorder in the depressed phase, or mixed states, which, as you may know, is when you have both depressive symptoms like really low mood and hopelessness and feeling really bad and being unable to enjoy things, but combined with the motor running really fast, racing thoughts, agitation, anxiety. Those mixed states are also high risk. If someone has depression, but they also have delusions and psychotic features to their depression, that's really the highest risk diagnosis. And in general, that's really more or less a medical emergency, and that's when we really want to act quickly. When people have concurrent alcohol and substance use disorders, especially alcohol and opioids, that definitely increases risk. And personality disorders, borderline personality disorder, antisocial personality disorder in particular, are definitely higher risk conditions than the general population. I want to speak for a minute just about substance use disorders alone, because society tends to think of substance use disorders as kind of separate from mental illness, and we tend to treat people differently. But really, first of all, there's so much comorbidity. It's almost impossible to think about them separately. And substance use disorders are not just a comorbid risk. Having a severe substance use disorder does increase suicide risk. People who drink alcohol heavily have about 5 times the risk of social drinkers. People with an opioid use disorder who are using IV heroin have about a 5 to 10%, about 5 to 10% of their deaths are by suicide. When people have chronic pain, that increases risk. When they are misusing opioids in addition, they have a significantly increased risk from there. And the last thing I'll say about this is I mentioned that the suicide rate in the country is going up. Well, we also all know about the opioid epidemic. And as it turns out, if you really dig into those numbers, what you start to learn is that there are almost certainly quite a number of suicides embedded in the opioid overdose statistics that get coded as unintentional or unknown. So if you look at it that way, the suicide rate is going up over the last decade, but it's really going up even more than we think, because a lot of people are out there playing Russian roulette with their opioids and just perhaps getting to a point of what difference does it make? Do I live or do I die? I might as well just do this. And we're not counting those, but we should be, because those are mental health issues as well, and they're counting as suicides, even though they're not being credited that way. So other risk factors. Men complete suicide significantly more than women, about almost 4 times as often. But women make many more attempts. And that's really basically based on choice of means. Men tend to often choose more lethal means, like firearms or hanging or jumping. Women often choose less lethal means, such as overdosing. And that's really the difference, because women are actually attempting suicide significantly more often than men. There are racial differences with particularly Native Americans and Alaskan Natives at highest risks, and whites at higher risk than African Americans and Hispanics and Asians. Another important issue is family history and genetics. A family history of completed suicide or of suicide attempt in first-degree relatives does confer some increase in suicide risk, and that's one of the things we ask about as we do a risk assessment. When you look at, if you read an article about suicide risk, they'll say, well, has there been an adverse event? Now, there's no one here to raise their hands because it's a webinar, but if I asked everybody to virtually raise their hand and ask who has not had an adverse event in their life, I don't think anybody would raise their hands. So I think the way to think about this is, has the person had an adverse event in the recent past that they have experienced as really catastrophic and devastating? That really, is a time to think about, well, is there a risk for suicide? Is there physical illness and chronic pain, some decrease in the health status? And anything that decreases connectivity to other people, engagement with other people, confers statistically an increased risk of suicide. So if somebody's widowed, divorced, single, living alone, unemployed, retired, socially isolated, those are all risk factors for suicide. Now, with younger people in particular, it's important to know something about the issue of exposure and suicide clusters, and we've all heard and read or maybe experienced something about this. It's especially important for adolescents and young adults who are the most malleable in this way. When young people are exposed to a suicide, either through the media, through social media, or through a friend making a suicide attempt, or someone at the school, or a suicide completion, that really puts other people at risk. It models something that makes suicide potentially more acceptable. There are a lot of adolescents, teens, and young adults who are really struggling out there, and we don't necessarily know it. Then something happens like this, and suddenly that angst that they're feeling translates to, well, maybe I can get rid of this by doing this too. About 20% of adolescents have a friend who's made a suicide attempt, which is a remarkable statistic. And friends tend to cluster with other friends who just have similar issues and problems. So when a friend makes a suicide attempt, it may expose vulnerability in some of their friends and make them more likely to act as well. So it's a really important public health issue for schools. And of course, how we talk about suicide in the media and among ourselves and in schools can make a really big difference. We've learned a lot about that. It's important not to glorify suicide or talk about it as a solution or make it heroic in any way. And there's a whole other topic that we could talk about social media and how we've kind of lost control of the message in some ways. But it's a very important issue. Another issue of the day, and particularly for teens and young adults, is the issue of bullying and cyberbullying. So a startling number of kids in schools report involvement as bullies or as victims or as both, bully victims, some of one and some of the other. And same for cyberbullying. And it turns out that both victims and the bullies themselves are at risk for suicide and suicide attempts, both in the near term and as they get into young adulthood. And it may be the ones who are both bullies and victims who seem to be at highest risk. So another really important risk factor is firearms. So having a gun, first of all, more than 50% of suicides in the U.S. occur by firearms, more than all other methods combined. It turns out that we in Massachusetts are fortunate in that the suicide rate by firearm is significantly lower than a lot of other places, and it is not the most common method here. About 24% of suicides by men and about 11% by women. And that's probably related to the fact that there are just fewer guns available and fewer guns in homes. The suicide rate does track state by state with the rate of gun ownership, independent of other variables. And having a gun in the home increases the risk of suicide, not only for the gun owner, but for everyone in the home, including children and adolescents in the home. Now, not everybody wants to get guns out of their home, and that's fine, and that's their right. It is good that people think about storage of firearms if they do keep them at home. Storing firearms without ammunition makes it safer. Locking the firearm makes it safer. Locking the ammunition in a separate place makes it safer. All of these things make a difference. So why is it that firearms are such high risk? Well, maybe this is obvious. But first of all, firearms are quick and deadly. About 85% of attempts with a handgun complete the suicide. So they're really quick. There's no time to intervene. And suicides and near-lethal attempts are often impulsive. People who've made serious attempts have been asked, well, how long did it take you between thinking about it and acting? And about a quarter of them say within 5 minutes, and about 50% say within 20 minutes. Almost three-quarters say within an hour. So having a quick and deadly method at your disposal is part of what increases the dangerousness. And so I also said we look at somebody's clinical condition. There are some clinical symptoms that we know are clinical risk factors for suicide, and we think of these as what we call modifiable risk factors, something that we might be able to treat and do something about and actually lower somebody's suicide risk. So we've already talked about some of these. Depression with psychotic features. So if someone's psychotically depressed and we can treat them with antidepressants and antipsychotic medication or with ECT and make that better, we're hopefully really lowering their suicide risk. Substance use disorders, we talked about that too, especially with chronic pain and opioid misuse. So if we can help someone achieve sobriety, we've made a big difference. Hopelessness is another one, which we actually, we can be hopelessness about helping people with their hopelessness, but there isn't reason to be. We can help with hopelessness. There's a number of studies in which psychotherapy has helped people who feel really hopeless feel less hopeless and then make fewer suicide attempts. Anxiety and agitation is something that if we tune into, we can sometimes treat and make better. And sleep disturbances, particularly really severe insomnia, and also really frequent nightmares. People who have been traumatized and have a lot of disturbing nightmares. These things are put people at more risk, but they're also potentially really treatable. And as I mentioned, there are mitigating factors, and I said something about these before. And there are sometimes ways in which we can enhance these by helping people engage with their loved ones, by helping people re-engage with people with whom they've disconnected. Sometimes people get into a state where they think, well, nobody wants to be with me anyway, I'm not worth it. But if you can help them see that that's really a cognitive distortion, help them reconnect with the people in their lives, that can make a big difference. People's moral and spiritual beliefs matter. And so if we can engage with them around that and help them think about what they really want for themselves, that can make a big difference. And really, one of the major, quote-unquote, protective factors is having kids and family that somebody cares about. And so one of the things we can do as clinicians is really have an open conversation with people about what the impact of suicide would be on families, and that can sometimes really help people. Probably people know what this is a picture of, the Golden Gate Bridge. And I put this here just because it's really the suicide hotspot of the country and one of the suicide hotspots in the world. It still doesn't have a bridge barrier, even though it is a location that people actually go specifically to kill themselves, and people jump from this location almost every other day. So what that leads me to is this next statement. If you stop someone from killing themselves one way, they'll probably just find another. This is one of the main reasons. This is a statement that is a widely held belief and is one of the major reasons that even though we have been discussing putting a bridge barrier on the Golden Gate Bridge for 40 years, there is still no bridge barrier. Because in addition to the fact that it will cost some money and there are some aesthetic issues, what would it look like? There has just not been a deep belief that it would make any difference. And it's like these people are going to find a way. And the fact is that this is incorrect, and there's a lot of public health data to support that. First of all, many suicidal acts are impulsive, they're in the moment, and in the moment passes, they don't happen. There's no question that availability of lethal means makes suicide more likely. And means restriction, which is the term in the field for this, taking away lethal means works. If you put up a bridge barrier, will people go to another bridge and jump? Well, the answer is, well, some will, but not all, and many, many won't. There are a lot of public health examples of this. So in Sri Lanka, for example, they had a problem. Pesticides that were widely available were extremely toxic, so people were overdosing and dying. Instead of it being a low lethal method, it became a high lethal method. So what did they do? They did one thing. They stopped using those pesticides. And if you track the suicide rate, what happened was the national suicide rate went down, and there were no increases in hanging, jumping, shooting, other things. So it's not like there was this need for suicide that popped up somewhere else. In general, if we make the environment safer for people, less people die. Here's another thing that I've actually heard from people. Asking a depressed person about suicide might put in the idea in their heads. I'm worried. I don't want to ask. I don't want to make it more likely. I don't want to encourage them or give them the idea. So this is just not right. Asking about suicide just doesn't suggest suicide, and it doesn't make it more likely. And this has been found in lots of screening. That was an issue when we started screening kids in school. Some people were concerned, well, would it make suicidal thoughts or acts more likely? And it turned out not to be the case. Actually, the opposite is true. If someone isn't struggling with this, they're going to laugh it off and check no, or just tell you, no, it doesn't, of course not. But if they are, they're more likely to experience it as a relief than an intrusion. It's definitely, no one commits suicide because their father or mother said, are you having thoughts about hurting yourself? And they go, oh, good idea. That just doesn't work that way. More likely, if they're struggling with this, either they won't open up, but more often than not, they will, at least to some degree, and give you some signal that they are struggling, and maybe talk about it, because talking about it might actually help them feel less alone. The risk here is really in not asking when it's appropriate. And what we want to avoid is something I call the last straw phenomenon. Someone is struggling with this and they feel alone, and they think to themselves, well, I'm going to go to the doctor, and if the doctor asks me, I'm going to tell them. Or I'm seeing my friend tonight, and I'm obviously depressed. If my friend asks me about this, I'm going to tell them. Or if my mother asks me, I'm going to tell her, or my father. And then when that doesn't happen, they think to themselves, that's it. I'm just going to do it. So we really want to ask when appropriate. So here's another one related. There's no point in asking about suicidal thoughts, is there? If someone really wants to do it, they're just going to keep it to themselves. And actually, I've heard this even from professionals when I've given professional talks. And this is also essentially not true. Of course it's true that there are some people who are determined to kill themselves and are going to conceal it and are capable of doing that. But that's the minority of people. The characteristic state of feeling suicidal is to be ambivalent. You partly want to do this because you feel so bad and you can't stand it anymore. But you really also want to feel better and you don't want to die. And people are flipped back and forth, and struggle with that. It's more likely than not that people will share what's on their mind. And it's not unusual for people to say one thing to one person, one thing to another, or say they feel that way one minute and then they don't another, because this is what they're struggling with and they're going back and forth. And it's often, as I said, a relief for people to talk about it. And it's very important that we as clinicians know what people are saying to family and friends, because sometimes people will say something to a family member that's more direct and honest than what they might say to a clinician, or they'll say it in the moment, but then they feel better when they're talking to the clinician and it won't come up. So this kind of information is very important to us as professionals. So here's another true-false statement. Most suicides actually come out of the blue without any warning. And again, this is kind of along the same theme. That's also not true. Most people do communicate in one way or another prior to acting. That might be explicit, I feel like killing myself. It might be writing a note. It might be hinting life doesn't feel like worth living anymore. And so again, it's important that we take any communication to family, friends, professionals, non-psychiatric professionals really seriously. Another belief is that the people who talk about suicide aren't the ones who are actually going to do it. And that turns out to be incorrect. Again, most who are suicidal are ambivalent and do throw out hints or want to talk in some way. And it is true that some people will complete suicide without any communication, without talking about it. But actually, when psychological autopsy studies have been done looking back at the people who completed suicide and finding out what they said and what they did. It turns out that most made communications to professionals or family. And the saying that came out of the psychological autopsy studies was, the talkers turned out to be the doers. So I've been talking about this and hopefully not raising anxiety too much, but it's good to know what are the warning signs for suicide. We've talked about risk factors, but there are also some warning signs that family, teachers, friends can be aware of, because that might give us the inclination to ask what's going on and even to ask about suicidal thoughts. So one of the warning signs would be, is somebody engaged in any kind of self-harming behavior? Even cutting yourself, punching walls, burning yourself, hurting yourself in any way is a risk factor and a warning sign that something's not going well, and we don't want that to escalate and progress to something that might be even more dangerous. Has there been a change in how somebody seems to be? Are they feeling hopeless? Do they seem to be appearing more hopeless? Do they not seem to care anymore about stuff they used to care about? Are they talking about wanting to die even indirectly, even making jokes about it that they never used to make? Has there been any indirect communication, texts or posts on Facebook? Are they appearing to give up? Has there been a kind of withdrawal? Are they in their room now just on their social media and video games and just not talking to people anymore? And is there any escalation in use of drugs and alcohol? These are more objective signs that friends, family, teachers, and others can pay attention to. So here's another kind of true-false kind of statement. Well, if someone kills himself, he must have had a major mental illness. So this is really not true. The public health data, the public health message, and it's an important message, is that 90% of people who complete suicide have a major diagnosable mental illness. And that comes from these studies in which you go back and retrospectively look at, did someone have a potential diagnosis? On the other hand, there are other studies that show that at least 10%, maybe more than 10% of people didn't, even when you go back knowing they completed a suicide, they didn't have a major mental illness. And most people who have a severe mental illness don't go on to kill themselves. So it's not just depression or schizophrenia that causes suicide. There are people who are vulnerable to suicidal states, but only under certain stresses. So, for example, someone who, we may not realize it, but all of their self-esteem, all of it is tied up in being an incredibly successful athlete. For that person, an injury and an inability to compete and play might mean something different than the same injury for someone else. And for that person, it might be experienced as catastrophic and life-ending for that person, because who am I now if I'm not an athlete? And so it's not just mental illness and as we talked about before, the common final pathway with mental illnesses is getting into this unbelievably bad way of feeling, which people feel they need an escape from. So it's important to think about treating mental illness, but we also have to be aware that people can experience something that they feel is catastrophic and suddenly feel differently about themselves and their lives. Suicide is really an older white male problem. I actually heard this at a professional talk that I gave recently. And there's a reason for saying this. About 70% of suicides are by white men in the United States. But, and we've always taught that the elderly are at highest risk for suicide. And it is true that older white males are at absolute highest risk. Older white males over the age of 75 or 85 are the highest risk by far, the highest risk group by far for suicide demographically. But in the latest data from the CDC over the last decade, the middle age group, and they call this 35 to 64 years old, and particularly the older middle age, which sadly I'm a part of, the 50 to 65-year-old group, have had a dramatic increase in the suicide rate and have overtaken the elderly in aggregate as the highest risk group for suicide. The suicide risk for men is much higher than for women, but in the middle age group, women have gained at a higher rate. There have been an increase in suicide at a slightly higher rate than for men, which is certainly concerning. So here's another one. Well, he would never kill himself because, and you can just fill in the blank. He has so much to live for. He has such a great job. He has young children at home. He has such a loving family. He just paid for his vacation. He would never kill himself. He has this dog that he loves. He has so many friends. Now, all of these things can be mitigating factors, but none are protective. And we just can't know somebody's insides by looking at their outside. And we all know of people who seem to have everything, and then we hear this tragic story about how they killed themselves. And what's happening inside someone is not necessarily visible by all the things that they have from the outside. Here's another one. Let's go to the next one. This is with a female pronoun, just because I've heard this said more often about women. Oh, she's tried so many times. She doesn't really mean it. Or these are just gestures. They're not really suicide attempts, and she's not really at such high risk. And this is really not true. First of all, even low lethality self-harm increases the risk of suicide. So people who cut themselves, people who've been traumatized and burn themselves, people with borderline personality disorder, they are at higher risk. Secondly, there is the term gestures is really an outmoded term. Gestures implies that we know what people are thinking and we know what their motivations are. It's much more accurate to talk about non-suicidal self-injury or deliberate self-harm. So what we know is that somebody's hurting themselves and it's low lethality. And it turns out that there's something about the body that's protective, and when we're repeatedly hurting our own bodies, we're probably breaking down that protective barrier. And the more self-harm that somebody does, the more inured they get to that, and the more risk that they may be at. And the more suicide attempts they've made, just statistically, ultimately the higher risk of suicide they are ultimately at. So, I've kind of answered this one, but the suicide risk is low because the person hasn't made a prior attempt. And actually, we hear this from clinicians sometimes. And that's just not true. It is true that a previous suicide attempt is one of the strongest risk factors we have for suicide. So if we know someone's made a prior attempt, that's one of the things we factor into the risk assessment. And more prior attempts, higher risk. More lethal prior attempts, higher risk. So someone who's made really near lethal attempts before is at risk to do so again. However, probably a half to two-thirds of suicides occur on the first attempt. So not having made a prior suicide attempt, it's just not enough for us to think that someone's at low risk if there are other factors pointing us in that direction. A person who wants to commit suicide is probably going to get to do it, probably going to do it eventually. We probably can't stop them. So this is false. Actually, this has been studied, and even people who make the most lethal suicide attempt, people who have tried to jump off the Golden Gate Bridge, or the few who have survived, and there are some who have survived that jump, people who have tried to shoot themselves, people who have taken massive overdoses and ended up in the intensive care unit. When those people are followed over 25, 30 years, more than 90% of them have not gone on to kill themselves. Even chronically suicidal patients who are struggling with suicide throughout, it seems like, their whole lives, most of them do not go on to kill themselves. So what this tells us is the opposite is true. Rather than thinking, well, someone's going to kill themselves eventually, what's the point? We're not going to be able to help them. If we can engage, if we can help people with their hopelessness, if we can try to stay not hopeless ourselves, and keep trying to connect with them, keep trying to help them feel less alone, help trying to get them services, we might very well be saving their life. Here's another one. A lot of people have suicidal thoughts at some points in their lives. Well, I had to throw in one true, so this one's a true. There are a range of suicidal thoughts. Everything from what we call passive suicidal ideation, like sometimes I wish I didn't wake up, I feel so bad. Sometimes I wish I would just disappear, or I wish I were dead, but with no intent at all. And then there are specific thoughts like, well, sometimes I really think, I think about it. Sometimes I think if I did, I would overdose, but I don't really want to do it. To sometimes I really think about overdosing. Sometimes I really feel like doing it. To, I really think about taking an overdose, and I've been stockpiling my medicines, and I have it in my medicine cabinet. And it was hard for me to come here today because I was thinking about it so much. So you can see I'm walking you through kind of gradations of suicidality. And people do have suicidal thoughts at various points in their lives, just in the general population. In population studies, just general health surveys, people do have suicidal thoughts at certain points of their lives, particularly of the passive suicidal type. They're very, very frequent, and probably many, many people who are listening to this video, this webcast, have at some point had some kind of suicidal thought, and it doesn't make you a mental health patient, and it doesn't mean you're going to complete suicide. And actually, about 50% of college students in one survey said they had thought about suicide at some point in their life. About 15% had seriously considered attempting it, and about 5% or so had made an attempt. My friend just lost a family member to suicide, but I don't think I should say anything because I don't want to intrude. So that's not exactly a true-false statement, but I would just say that that's false. Survivors of suicide are in a terrible place. It's catastrophic. People feel grief-stricken, guilty, angry, upset. It's grief plus. It's just an awful place to be. But people are longing for human connection. Survivors almost always say they want contact from other people. They want to have people reach out to them. And they want people to work through the embarrassment because they want connection. That's what they want. That's what they need, just like any other loss. So that's avoidance. When we avoid because of our own embarrassment and discomfort, it just makes people feel less alone. Suicide can be prevented. This is a statement that is commonly used in public health messaging. So I would say, well, it's true on the one hand. There is much we can do to prevent suicide. We can do good risk assessments clinically. We can treat depression. We can treat modifiable risk factors. We can provide good care for mental illness. We can take steps to intervene when people need something more acutely, including emergency rooms and hospitalization. But it's also false. We can't predict suicide. If we can't predict suicide, we can't prevent suicide. Also, despite everything that we're talking about, there are some people who are capable of concealing what's going on inside of them and determined to do so. And there are also other people who really seem to be and are doing okay. They might be struggling, but they're doing okay, and something happens and they act impulsively before anyone can know and anyone can do anything about it. And about 5% of suicides happen in the psychiatric hospital when we know people are at risk and we're doing everything we can to make their environment safe, and we're checking with them multiple times a day. And even there, we can't fully protect people. So for me, the takeaway from this is that every suicide is a tragedy, but every suicide is not someone else's fault. And it's just important for family members of people who complete suicide to recognize that we can't always prevent suicide. It's not necessarily families, friends' fault. It's not necessarily clinicians' fault. This is just part of what we deal with in the field of psychiatry and in working in mental illness. we all have a role in suicide prevention. Well, I think I'm winding up the talk with a softball. So of course that's true. And actually I think that's one of the fantastic things that's happened over the last decade is there's just so much more education. Talking with kids now about this, you learn that they're getting so much more in school. And when something happens nationally, they're talking about it in the schools. When there's an event, they're talking about it. They're teaching kids how to talk to other kids and how to come to adults and why it's so important. So a lot's happening nationally around this that's so important. Doctors, teachers, friends, family, we've all got to take any warning signs seriously, any signs of depression seriously. If someone has a life crisis, we have to be thinking, well, are they in crisis themselves? Not dismissing what we see, even if it's tossed off as a joke. Being willing to bear some discomfort ourselves to ask the difficult question. And suggesting and facilitating professional help if needed, and even trying to ensure it if necessary. If you are scared that someone is unsafe, then get them to a professional, get them to the emergency room. Don't leave it with them, and that really might save a life. And I'm just winding up with a couple of resources here. One is a website from the World Health Organization that has its own list of myths that you might want to check out. And the other is the AFSP, the American Foundation for Suicide Prevention website that has a lot of useful information.
Great. No, thank you, Dr. Schechter. That was a wonderful overview of suicide and the risk factors, mitigating factors, other things. We've already got some questions. I want to remind our participants, if you do have a question, please type it in the Q&A box, and we'll put it in queue and get through as many of them as we can. So one person asked, if you become aware that someone you know is having suicidal thoughts, can you outline some of, this person says, what's the best way to talk to that person? But maybe can you outline some approaches or some things to think about in terms of how do you bring up the subject? What types of things are helpful to say? What types of things should be avoided? Because I think a lot of, you alluded to this in some of your true-false questions, like you shouldn't, don't talk, do talk. But people are still, I think, really confused about what do I say?
Yeah, no, that's a great question. So I think a willingness to ask is bring it up is so important. If you have a family member who's clear, or a friend who's clearly struggling, who's depressed, it's good to start general. You can ask, and you can preface it if you'd like, say, listen, I feel kind of embarrassed asking this, and I don't want to make you uncomfortable, but I care about you, so I'm going to ask. I care about you too much not to ask. I mean, I think anybody understands that, and that's relationship building. It's not relationship ruining. And then you might say, has it ever gone? I mean, you're obviously so depressed, and I feel terrible about this. Has it ever gone to the point where you think it's not worth living anymore? Then depending on the answer you get, if the answer is, oh no, well then okay, that's very reassuring. I'm just so glad. I won't ask again. I just needed to know. On the other hand, if it's, well, yes, sometimes, then you want to start getting a little more specific. Has it ever, is it something you really think about? Have you thought that you might actually do it, or have you thought how you might do it? And then if somebody answers at all in the affirmative, now we're talking about, okay, we really need to talk about getting you some help. And if they start to, and if you ask more specifically, have you thought that, do you actually have an idea of what you would do? And if they said, like, yeah, well, I have some pills at home that I'm thinking of taking, then you start to know, oh, this is an emergency with this friend of mine. This isn't just someone who's struggling and, well, I'll see you tomorrow. This is an emergency, and we really need to talk about how we got to get you some help. I'm going to call, and then you start to talk about how can you intervene.
Okay. And so Another question, a couple of people have asked a similar question. And, this series of webinars is focused primarily on borderline personality disorder. And one of the symptoms or traits of borderline personality disorder for some people is chronic suicidality. And for some people, chronic threat of suicide or chronic talking about suicide. So one person asks, is there anything I can do proactively to manage this never-ending series of suicidal threats? This person says, I treat them all seriously, but is there any way I can stop the revolving door? And I think the bigger question is, do you have any thoughts or guidelines about helping people change the conversation from suicidal threat to pain and suffering or to something else? Or is that unwise? Is that not recommended? Because, as you said, if they're experiencing the thoughts and threats and making the threats, they could do it. And there's a reality that they could do it no matter what anybody does. But any recommendations for, let's start with family members, and then I'm going to go to professionals even who are chiming in.
Yeah.
But for family members.
So let's start with family members. This is such a great question. It's such a difficult problem. And if I had the answer, I don't know where I would be.
Yeah, Nobel Prize.
I would have the Nobel Prize. Thank you. If I had the answer to this, I would have the Nobel Prize. I'd say for family members, it's extraordinarily difficult and agonizing. I'd say working closely with the clinician who's working with your loved one can be extremely helpful because there are times, and Chris, I think one of the things in your framing this question is sometimes when people are making these suicidal statements, suicidal threats, particularly when they're chronically doing that, it's also their way of just expressing, I'm just so unhappy. I'm suffering so badly. I can't bear it, and I'm not actually acting on it, but I'm acting on it by telling you I'm going to act on it. That's my way of acting on it. And it engenders a whole cycle of things that start to happen, interventions and hospitalization. And those things are sometimes helpful, but in the setting of borderline personality disorder and chronic suicidality, the clinicians and the family have to start to make a determination what's helpful and what isn't helpful. Because repeated hospitalizations, sometimes are less helpful than figuring out what these expressions really mean for this particular person. And in that situation, does it make sense to say, listen, I know when you say that, I think you're really in pain. Tell me what's going on? And having some conversation to try to address the suffering and then say, do you still feel that way? That might be one thought of an approach, particularly if the person's therapist and psychiatrist have a conceptual frame that this particular person is going to, that they use expressions of suicide, of suicidal ideation as a way of expressing their suffering, and they're not always accompanied by real intent, then it does make sense to try to have some discussion and try to sort that out rather than just keep sending someone to an emergency room where we know what happens when they get there and it's a really horrible, dehumanizing experience and may not be in their interest. So I guess it's a long discussion in terms of how you'd really think about that with each individual.
Do you think that people, even a small percentage of people, ever use repetitive suicidal threats to try to make the other people, especially family members, just as hopeless as they are, to somehow kind of justify suicide? They're like, as long as you have hope for me, Mom or Dad, I feel too guilty about doing it, so I'm going to keep badgering you with my hopelessness and my suicidality and try to beat you down and try to get you to say, okay, if you're going to do it, you're going to do it. I have no control. I don't know how to help you. We've sent you to all the best people we can find, and they haven't been able to help you. And then somehow it feels like, okay, now maybe I have permission.
Yes. I think that's a great question, and I'd say a couple things about it. One is that actually all of us do, I'm going to just share this, a kind of a version of this, not quite the same, but all of us, what we do, we feel a certain way about ourselves, hopefully reasonably positive in many ways. But what we do is we act in a way with our friends, with our family members, with our colleagues, with our supervisors and bosses. We act in a way that actually ends up evoking from other people something that kind of fits the way we feel about ourselves already. And there's a lot of research about this. We actually act in ways that tend to confirm our self-concept. And that's often a good thing. It helps us feel good about ourselves. If I feel reasonably good about myself and I expect a positive interaction with someone I meet, I get it back, and that bolsters my good feeling about myself. But that takes on a negative turn in this situation. So I feel horrible about myself. I feel worthless. I feel hopeless. I feel like I might as well just be dead and no one would care. And then I start to evoke those same kind of responses. I act in a way that's going to get you to feel the same way that I feel about myself and to treat me that way. And that's when it gets scary. People get clinicians to act this way towards them and to give up hope, and they get family members and friends to give up hope. And they're exquisitely sensitive to that, and they sense the subtle withdrawal or the fine, just do it already. And it makes it easier to act. It makes them more able to, because they are ambivalent almost all the time, and they do often have some awareness that they don't want to kill themselves because of other people. And the fact that they then evoked this response in other people that causes them to be, in their view, kind of treated so badly and like they're worthless, it makes it easier to act.
And so another question, which is a common question that comes up, can prolonged use of psychiatric medication or being on multiple psychiatric medications actually cause suicidality?
Yeah, so that's a really good question. So, and the big controversy has been with antidepressants, and particularly antidepressants in younger people. So let me just speak about that for a second. For all the antidepressants have what's called a black box warning that basically says doctors need to warn everybody that the antidepressants can increase suicide risk, particularly in people under the age of 24. And that came from when they did the studies to approve antidepressants for use, which were usually 8 to 12-week studies. In adolescents there was a 4% incidence in what they called suicidality, which was any kind of expression of suicidal ideation or self-harm or suicide attempt, anything, as compared to placebo, which was 2%. So there was an increase, and that was enough for them to create the black box warning. It wasn't correlated with suicide itself. And in young adults, it wasn't statistically significant, but there was an echo of that, so they made the black box warning for both. But on the other hand, there's a lot of data now that shows that the risk of suicide is highest before people come for treatment, whether that treatment is psychotherapy or whether that treatment is psychiatric medication intervention, antidepressant or other. And then that risk tends to start to go down as treatment happens. I think that there is always some risk with medication, not just psychiatric medication. There are other medications too that can cause somebody to feel really bad inside. They can cause what's called akathisia, which is a physical restlessness, a feeling like your muscles can't stop moving and you're physically uncomfortable. Medicines can cause anxiety and agitation, can cause mood lability, and that's true with a lot of medicines. I just saw someone who was put on steroids because she had asthma. And she became out of her mind, tearful, agitated, couldn't sleep, and that was from a medical medication. So I don't think there is any evidence that using medication causes suicide. I do think we need to be sensitive to any time that we start a medicine or increase a dose, that we make sure that everybody knows, patients and their families, that should they feel worse, should they have side effects, should they have any emergent suicidal thoughts, which can happen, that we know about it and we do something about it. Now, in terms of more than one psychiatric medication, there's really no evidence that adding medications increases suicide risk. And actually, in the field in psychiatry, what we're finding is that actually it's the more unusual case that somebody with severe depression does get better with just one medicine. So what we're finding is that a certain percentage get better with one, switching gets another percentage better, but it's not at all uncommon that we need more than one psychiatric medication to treat depression and other mental illnesses. And particularly when we get into the idea of the realm of treatment-resistant depression, we may need combinations of several different medications to help someone feel as well as they can. And ultimately, treating the mental illness as well as possible is what's going to help most in terms of lowering risk.
Great. Now, thank you, Dr. Schechter. So, unfortunately, we are out of time, and so we are going to have to end for today. And I want to just call people's attention to the screen in front of you. Our next webinar is Thursday, December 7th at 11 a.m. Eastern Standard Time. Borderline personality disorder and complex post-traumatic stress disorder. And you can register for that by clicking on that link or coming to our webpage. I want to thank Dr. Schechter for a wonderful presentation and Q&A session, and